Hello, everyone. I'm very honored to talk on OCT angiography in OBF assessment today. My financial disclosure here. We all know that intraocular pressure is the most important risk factor for glaucoma pathogenesis. However, ocular blood flow has also been an important issue, especially in normal tension glaucoma. There have been various devices used for measuring OBF, which include color Doppler imaging or laser speckle flow meter. The indirect clues of OBF, such as blood velocity or retinal vessel caliber, have also been used for research. The problems with these techniques include lower reproducibility and target tissue ambiguity. Now we have OCT angiography, and we can measure blood vessel density at different locations and at different tissue depth. The vessel density measured by OCT A is believed to reflect the flow of red blood cells. I've summarized some pros of OCT A. Firstly, OCT A shows better structure-function relationship in moderate to advanced glaucoma in terms of circumpapillary or macular capillary density. Secondly, using OCT A, we can observe novel pathologic findings like choroidal microvasculature dropout. Now let's get into more detail. First of all, I'll be on circumpapillary capillary density or CPCD. In this longitudinal study, recently pressed in AJO this year, the authors looked at the association between progressive retinal capillary density loss and visual field progression in OAG patients according to disease stage. In this study, 89 eyes had early stage disease and 69 had moderate to advanced stage disease. Serial CPCD and circumpapillary RNFL thickness measurements were performed during mean follow-up of more than 2 years. What they found out was that mean rate of change in CPCD was significantly higher in moderate to advanced stage than that in early stage. In contrast, there was no difference in mean rate of change in CP-RNFL thickness between moderate to advanced stage and early stage. In this patient with early glaucomatous damage when enrolled, but rate of change in CPCD and CP-RNFL thickness showed progressive decrease consistently with visual field progression. In contrast, another patient with advanced disease showed that progressive CP-RNFL loss was evident in correspondence to visual field progression, whereas CP-RNFL thickness was not progressive. These findings are very consistent with our cross-sectional study result. There, we revealed that there is less flow effect in CP-CD measurement than in CP-RNFL thickness measurement. Next, macular capillary density, or MCD. They also investigated the relationship between macular vessel density and central visual field sensitivity at different glaucoma stages. In this study, macular GCIPL thickness and MCD were measured, and the association of these parameters with central VFS was sought. We observed very similar findings like in CPCD as previously shown. There was better association of MCD and central VFS in moderate to advanced glaucomatous stage, but not in early glaucoma. And MCD to CVFS relationship was stronger than the structure function relationship using macular GCIPL thickness in moderate to advanced glaucoma, implying there is less flow effect also with MCD. Let's look at the representative eyes. In these eyes with different degree of central visual field defect, MCD values showed a noticeable difference, whereas macular GCIPL thickness showed a flow effect without a significant change. Moreover, the vascular dropout at the macular region, marked as arrows, showed a good topographic correlation with the central visual field defect. Lastly, I'll mention choroidal microvascular dropout, or CMVD. Using OCT A, CMVDs are typically observed within the parapapillary deep layers involving beta and gamma zones within the PPA. Subsequent studies revealed that CMVDs also associated with progressive RNFL thinning and visual field progression. In this patient, CMVD was observed in inferior parapupillary area by OCT A. Notably, there was fast visual field progression at the central and superior region during follow-up. This is in correspondence with the location of CMVD at initial presentation. In contrast, another patient without noticeable CMVD by OCT A at initial presentation showed relatively stable visual field status. Now let's think about the cons of OCT A. First of all, OCT A has limited diagnostic ability. Most of the articles shows that OCT still outperforms OCT A in terms of glaucoma diagnostic ability. AURC values were consistently better with OCT parameters such as neuroretinal rim area, RNFL thickness, or GCC thickness than those acquired by OCT A vessel densities. It is also difficult in getting reliable images by OCT A due to various artifacts, and the OCT A values are so vulnerable to signal strength. In addition, we don't have any normal database nor automated change analysis program available in clinic setting. I also would like to mention OCT A's future investigation. In our article pressed a few years ago, we analyzed the foveal avascular zone using OCT A because FAS in glaucoma is of great interest in that this area is highly vulnerable to ischemic change. As with the fact that the fovea is surrounded by a single-layered perifoveal capillary arcade, we can assume that ischemic stress may result in the disruption of FAS shape and easily observed by OCT angiography. OCT A FAS-related parameters are its size, perimeter, or circularity index. Let me show you some cases. Only glaucomatous eyes in orange box tend to have irregular FAS borders or with low circularity index, and advanced glaucomatous eyes in red box tend to have notably enlarged FAS size. Diagnostic accuracy of FAS circularity index seemed a bit weak, but statistically comparable to conventional OCT parameters such as parapupillary RNFL thickness or macular GCIPL thickness. Lastly, I raise a curiosity to you. It is well known that some types of kidney disease begin from the breakdown of the capillary system of glomeruli. I believe that similar things can happen in glaucoma, and I'd like to ask you this question. Do some types of glaucoma begin from the breakdown of the capillary system of macula? Of course, I don't know the answer. However, we already know that non-IOP factors for glaucoma progression exist, especially in NTG. FAS analysis using OCT A may give some potential clues to investigate ischemic damage in macular area associated with glaucoma. Take-home message. OCT A may be a better monitoring tool in eyes with moderate to advanced glaucoma, although its general diagnostic ability is limited. And OCT-A specific novel vascular findings such as CMVD or FAS-related changes may be of help for future glaucoma research. Thank you very much.